Thank you very much. Can everybody hear me? I'm loud, so, okay. All right, I'm glad you brought up LivingWorks because I am also a LivingWorks trainer. So my name's Kimberly Curnan. Like John said, I am the 98 director at 211 Tampa Bay Cares. We are the 211 that covers Pinellas and Hernando counties for the information and referral piece of our work, but we are also a 988 center, and we're going to talk specifically about that today. I've been at the agency for almost 12 years. I've been working on the phones when I first started, and I talked to people who were suicidal, in crisis, homeless, all those different needs that I'm sure you guys are aware of in your community. And then slowly I moved up in the organization, and then last year when we got our 988 contract with Vibrant Emotional Health and SAMHSA, I became the 988 director because I have the training experience and all that good stuff. So what LivingWorks is, that John was talking about, it's a entity that develops training curriculum for communities all across the globe. So they structure and they standardize their suicide intervention skills training to make sure that no matter where you are as a participant in one of those classes, whether you're here in America, over in Australia, somewhere up in Canada, the message is the exact same. Maybe there's a little bit of language change for culture differences, but the training is exactly the same. So by all means, if you guys have the ability to get involved with LivingWorks, they do some amazing trainings. On this page here, you'll see that it says I'm an assist trainer. That is a LivingWorks training. It stands for Applied Suicide Intervention Skills Training. It's very deep end, 2 full days, 8 hours each day. It's in person. We're not allowed to do it virtually. We have to do it in person. But really goes into a deep dive into our own attitudes, beliefs, and how to de-escalate and safety plan with someone who is having thoughts of suicide. So if any of you are interested in ever getting one of those trainings, my cards are back here. Feel free to pick up a card, reach out to me, and we can talk about getting training for you, your staff, anyone in the future. This is a really informal presentation. I'm not a formal person, okay? So if at any point during this conversation something doesn't make sense or you have a question about something I haven't covered, just shout it out, raise your hand, do whatever you want to do, and I'll stop and we can discuss it on the way. All right, so today we're going to talk about the 988 implementation and give you some facts about what happens on 988. We're also going to talk about what somebody can expect when they reach out to 988 and what we do when we talk to somebody. We're going to talk about least invasive intervention and what that means for a suicidal caller. We're going to explore our attitudes, or at least discussing the need to explore our attitudes. We'll talk about some warning signs and how to explore possible thoughts of suicide. We'll talk about how to ask if someone is suicidal and what you'll hear if they say yes. How to respond and find hope in those hopeless, what seems like hopeless situations. And then we'll talk a little bit about who can help you with those people who are suicidal. And then I always finish every presentation with a self-care moment to remind you that the work we do is very difficult. It is not easy. And if we're in crisis, it's very hard to help somebody else in crisis. So taking care of ourselves is a priority. So let's talk about 988 and let's go over some fast facts. So 988 is the same thing as the National Suicide Prevention Lifeline. What happened was in 2022, we were able to adopt a 3-digit dialing code to make that suicide hotline easier to remember. That is the only difference, is that instead of having to remember a 10-digit toll-free number, now all you need to remember are 3 digits. So you get the cops when you call 911, you get information and referral when you call 211, and now you get the suicide hotline when you dial 988. You may see things on social media or promotions out there that promote the Veterans Crisis Line or the Veterans Suicide Hotline. That's us too. All you gotta do is dial 988 and push 1, and then you get the Veterans Suicide Hotline piece, okay? We also have partnerships with, or sub-programs in 988 that takes care of the LGBTQ plus community. So if you have somebody in the LGBTQ plus community who wants to talk to a peer in that community, they just have to push 3 when they dial 988. If you have somebody who speaks Spanish, they just have to dial 2 when they reach out to 988. And then in times of disaster, there's also Lifeline disaster services when there's a global disaster or a national disaster going on. We have two different departments at our agency. We have our 988 department and we have our 211 department. Like I said, today we're just going to focus on the 988 side of the house. But if any questions come up about 211s, feel free. I used to be the 211 manager, so I can answer those questions too. But in our 988 department, we do have two different teams. We have a phone team and we have a chat and text team. The chat and text team is 24/7, the phone team is 24/7, but they do not cross over. Our staff is dedicated to one form of media based on the contracts that we have at our organization. So the chat and text team is answering chats and text messages from people who are reaching out to 988 on those platforms from anyone across the country. It's a national backup team, which means they're answering chats and texts from the continental U.S., including the 3 territories of Guam, the U.S. Virgin Islands, and Puerto Rico. On the phone side of the house, that is a local contract with the state, with DCF and Central Florida Behavioral Health. So with the phone contract, we are set up under our contract as the primary 988 center for 9 counties. Those 9 counties are Pinellas, Pasco, Hernando, Sarasota, DeSoto, Manatee, Hendry, Lee, and Glades County. And what that means is if somebody from that county calls 988, that phone call is going to come to our center first. And it's going to sit in our call queue. Yes?
I apologize.
Yes.
A lot of people like me don't have a 941 number.
Correct.
Are you going to touch on that?
Yes, I'm going to talk about that in 1 second. Absolutely. Very good question because it's a big deal. And that's a very important question. So if somebody calls us from one of those counties, it's going to come to our center first. It's going to wait in our call queue for about 120 seconds to see if one of our staff are available to answer. And if none of my staff are available to answer because they're on the phone with somebody else, that call is going to automatically bounce to the backup center that's been assigned to that county. Every county has different backup centers depending on who's answering it. And then it'll sit in that backup center for another 120 seconds waiting for somebody to answer there. If nobody answers there, then the call automatically routes up to a national backup center somewhere across the country. New York, California, Miami, somewhere. And the purpose of that is that so there's several levels of centers out there ready and able to answer that call so nobody has to hold longer than they need to, okay? When it comes to the phone calls, very good question. Vibrant Emotional Health, who controls the phone system for 988, they have set up the phone system to be based on the phone number, not your location at the time of the call. So what that means is that they take phone numbers, all the phone numbers in the world, or all the phone numbers in the U.S., and they go by the first 3 digits of the phone number and the area code. And that's how they would assign a phone number to a specific county. How does that cause challenges? Because people are going to keep their phone number and they're going to move over to California, they're going to move to New York, anyplace else. So our staff are constantly getting phone calls from people with, Lee County, Sarasota, Manatee County phone numbers, but they've moved somewhere else. Doesn't mean we can't help them. We're going to continue to help them. But if they ask for any local resources, we're going to tell them to call their local 211 for local resources. Or we can transfer them to their local 211 because we have that capability as well. So that's the biggest challenge that we have when it comes to the calls that come into our center is that people keep their phone number and they move to other locations and now they're no longer local. Vibrant Emotional Health is working on that. All of us are complaining as centers that this is not right. We should not be doing this to our callers. And they know it's an issue. They're working on it, but it'll be a while before that gets fixed. It's a bigger job.
Is it like due to privacy, like where do you find me? Is that it?
No, it is actually because when they set this up 30-some years ago, cell phones were not that common. And so they based phone numbers off of landlines. And now they've got to and when you think about how because I hear the story from my CEO because she was here with our organization when 211 became a 3-digit dialing code. And it's not just the cell phone companies you have to tell, it's businesses in the area like hotels that don't allow you to dial out of their business. Like there's so many levels of people that you have to get on board. It is a long process to change that. But they are working on it and they know it's a priority. On top of the 9 primary centers or the primary counties that I talked about, we are also the backup center for Hillsborough. So if somebody has a Hillsborough County phone number and they dial 988, it'll go to the Tampa 211 first, they're the primary, and if they can't answer within 2 minutes, it'll roll over to us. And then if we can't answer, it'll roll over to the national backup centers. So we cover those 10 counties. As you can imagine, some of those counties, Hillsborough, Pinellas, very, very populated. Those are very large communities, very big geographically. Hillsborough is huge when it comes to how big it is. And so we have one of the highest volumes of calls in the state of Florida. We average about 1,800 phone calls per month to the 988 phone team, and we average about 3,000 chat and text messages per month to our chat and text team. 988 is available to anywhere across the U.S. It's 100% coverage, so anywhere you are at the time of your phone call, you will get routed to a center that'll be able to answer your call. It's free, it's confidential, and it's anonymous. People do not have to share who they are, they do not have to identify themselves, they do not have to tell us where they are. But we do have some tools to try to help us locate people in case there are medical emergencies. On the chat and text side of the house, they utilize a database that Vibrant Emotional Health controls. And in that database, we have a locator for people that are reaching out through us by chat. And it gives us a possible location based on their IP address. So in case they tell us that they've already started their suicide plan and now it's a medical emergency, we can start reaching out to those law enforcement agencies in their local area. We also have a tool that allows us to find all the 10-digit numbers to all the law enforcement agencies across the country for situations like that. I put the website there for you as well. If you look back here, I put business cards for the programs. There's Spanish and English back here. There's QR codes on the business card, so if you scan the QR code, it will take you to that website so you can see what's available for the clients. So when somebody reaches out to 988, what can they expect? We are at the mercy of our funder like everybody else is, right? There's expectations, there's reporting, there's guidelines that we all have to follow for whatever program we're part of. For the 988 program, we have very specific guidelines on things that we are required to touch on during conversations. Whether or not the person answers it, that's a different story. But we are at least required to explore these main points for every single interaction that we have, regardless if it's phone or if it's chat or text. So the first thing that we look at is the active engagement piece of things. When somebody reaches out to us, we're not going to automatically start going into where are you safe, we're going to give them the space to talk to us and share their story about what's going on. Maybe they're not the one who's suicidal, maybe they're worried about somebody else. A lot of times we get people call us and say, I'm not suicidal, don't call the cops on me, I'm just here to talk. That's okay too, that's what the hotline is there for as well. So giving people space to share, validating their feelings. We get a lot of criers, a lot of angry, frustrated people who are yelling right off the bat. Being able to take a step back, give them their space, and validate that it sounds like you're going through a really hard time right now. Crying is perfectly normal. Take your time. I'm here for you when you're ready to talk. And sometimes my counselors just need to be quiet and let them get out whatever they need to get out. The next piece of the conversation is exploring our situation. So we're probing to find out what's going on, what made you reach out today, what's happening, how long have you been suicidal, let's talk about what your thoughts are all about. And then we're doing more space and more active listening because their story's not over yet and they're still telling their story to us. After that, and after a few minutes, we do want to make sure that we are fairly early in the conversation assessing their safety and their risk. Because before we get into any other kind of de-escalation, I want to make sure, are you even safe to have this conversation? So we're asking them, are you suicidal? We're confirming those words with them. We're asking them if they have a plan. We're asking them if they've started that plan. Because if they already took the bottle of pills, if they've already done something to shoot themselves, stab themselves, putting the noose around their neck, whatever the situation is, we don't have the time to work with them. We need to get medical services out to them. But that's not a common case for us. Most times people just need to talk through their feelings. Okay? Then we work on, as long as we know that they're safe, we work on the collaborative problem-solving piece of things. So talk to me about how long you've been suicidal and what's worked for you so far. If you've been suicidal for 20 years, how have you kept yourself safe until now because you're alive today to call us? So what has been that thing to keep you safe until now? And why is that thing not working anymore? And let's talk about that. And when it comes to collaborative problem solving, that is a back and forth between our counselor and the caller. We can't be controlling that conversation. The problem solving needs to be put in the hands of the person who is having those suicidal thoughts. We can sit here and say all day what we think might work for you, but if it's not realistic in your life, then it's not going to work for you. So we need to make sure that we have that collaboration from our visitors that reach out to us. Then we work on safety planning. And safety planning has 6 different steps. We talked to them about their warning signs, and I saw some flyers back here that talked about warning signs for people who may be experiencing suicidal thoughts. We talk about their coping strategies, what has worked up until now. We talk about their distractions and their supports. Do you have places that you go? Do you have things that you do to distract yourself from these thoughts of suicide? Is there anyone you reach out to? Family, friends, therapists, mental health professionals? Who do you have in your life? And then we talk about keeping their environment safe, and this is the part that scares everybody. So we live in Florida, people got guns, right? People have guns. We can't convince people to get rid of their guns. We cannot convince people to get rid of their weapons. So how are we gonna work with this visitor to try to help them keep their environment safe, knowing that sometimes those weapons and those means are gonna stay in that home? So we try to do things as, best case scenario as possible. Can you give the gun to somebody else? Can you give it to somebody who can keep it for you? Most people aren't gonna do that, okay, especially with their weapons. So if you're not gonna do that, okay, what about locking it up in a safe? What about putting a gun lock on it? What about unloading it? What about putting it in another room? And we just keep getting it as far away as possible. And even if we have somebody that says, no, I want it to be here with me, okay, can you put it on the table and just not touch it? And that to us is a collaboration if they agree with that, okay? And we keep checking in later throughout the conversation. Just because you say you're doing it now doesn't mean it's not in your hand 30 minutes from now. So we'll keep checking in with them, but we need to be able to trust our visitors. If we want them to trust us and be honest with us, then we need to trust them and take what they're saying at face value. Okay. Once we get through a safety plan and we develop a safety plan, then we talk about wrapping up. What are we going to do once this conversation comes to a close? Are you comfortable with the plan that we've developed together? And are you having any hesitations about starting that plan once we hang up? And then we talk about connections to third parties if needed. I'll go over that more in a second. And then we talk about follow-ups. So as a requirement for our contract, we are required to offer a follow-up call within the next 72 hours to anyone who identifies as being suicidal in the past 24 hours. And as you can imagine, that's a lot of people. So we do a lot of follow-up attempts. Not everybody answers, but we do offer that to anyone who says that they've been suicidal. They have the right to decline it, and that's their right. They don't have to because there's some sensitivity issues. You don't want us calling you when family members are home if you don't want them knowing about our conversation. So we offer that, but they have the choice to decline it. When it comes to the connection of third parties, we talk about who our handoff is. And a lot of times we don't have a handoff. If we can just de-escalate a conversation, come up with a safety plan together, that's the majority of our phone calls. We don't need to do any more handoffs for a lot of our callers. However, there are times where there's medical emergencies or mental health serious issues, maybe not emergencies, that we do have to get other parties involved. So when it comes to our expectations at 988, we have to follow what's called least invasive intervention. Yes?
I have a question.
Yes.
So when you're going through your process, on the previous slide,
Yes.
at what point do you feel that you need to call mobile crisis if you can't get to that?
That's what we're talking about right now.
Okay.
Yeah, right now. So when it comes to least invasive intervention, we have to follow the guidelines of Vibrant that says we are going to try everything we possibly can in our toolbox to de-escalate a situation before we involve a third party such as law enforcement, okay? We all know that there's not enough crisis training for our local law enforcement. They are not the best people to respond to our clients who are going through a mental health issue, and it can be dangerous sometimes. So what we try to do is we try to de-escalate and see if they can safety plan with us. If we have clients that are safety planning, but they're still worried about their immediate future after we hang up, they're going through mental health issues, and they are not a weapon emergency or a medical emergency. So they can't be brandishing weapons, they can't have already taken the bottle of pills, but if we've got somebody who's going through a mental health crisis, maybe active psychosis, maybe they just don't have any mental health services and they just don't know who to turn to, and they don't know if the safety plan is going to work for the next 5 hours, but it'll work for the next hour, then we connect those people to the mobile response teams. So we have mobile response teams in all the counties that we cover. We have MOUs, or Memorandum of Agreements, or understanding, sorry, MOUs, with all of the MRTs in the counties that we cover. And we meet on a monthly basis to say these are the referrals we've sent over to you, to your MRT. Are you hearing anything else? Are these appropriate referrals? Are you okay with who we're sending over? To make sure that we're all on the same page about the type of client we send to a mobile response team. So medical emergency or somebody who refuses to stop brandishing a weapon, that's 911, that's the cops. For somebody who is not brandishing a weapon, has not started their suicide plan, but needs that extra level of support from mental health services, that's the MRTs. And then everybody else who just needs to talk and vent through their frustrations, that's just us on our side, and then sometimes we'll refer to 211 for some local resources later. Any guess?
What does it look like when the MRT gets involved?
We just had this training the other day, so we had our MRTs all come onto a Zoom meeting with my staff and really talk about what does that look like when you guys go out there. So depending on the MRT, they can initiate a conversation with a virtual meeting first. They don't have to necessarily go out to everybody, but they have the option to do virtual meetings. They go out to different locations. Most of them will bring a law enforcement agent with them for their staff safety, okay? And if the client is super scared about the law enforcement officer coming out, they will have that conversation with them first, whether by phone call or through a virtual meet and greet. I know that there's a lot of follow-up services that the MRTs will provide. They provide connection to local resources in their community. Is anyone here from an MRT? Oh, here we go. So maybe you guys want to talk about what you guys do specifically here.
I responded to a 988 handoff last night, that's why I was asking.
Oh, okay,
She
great.
was actively suicidal, said she wanted to slit her wrist. You guys did a one handoff to us. We respond with a dual response, so either two therapists go out together, depending on the shift. So some night, I work till 10 o'clock at night, so sometimes after 10 o'clock at night, if I'm responding and no one else is on with me, I will respond with law enforcement. I do let the client know for their safety and my safety, law enforcement has to come, but that they be talking to me. I responded to a call with a gun in the home with law enforcement. So normally what happens is you guys do a one handoff, so their staff is on the phone with us, with the client. Sometimes you can get demographics. Last night they weren't able to, so we got it. The therapist that I responded with is licensed. He was triaging. He just texted me the address, me and him responded. We did a warm handoff to PEMS, because that's who we work for. And we just walked her in to the unit. She signed herself in voluntarily.
So are you nurses or?
No,
No,
we're
we're
mental health
therapists.
therapists, master's level.
you're
We're all mental health therapists with our master's level.
Okay.
And if someone has to be Baker acted, since we cannot transport, and that's when the Leo would
Yeah, we
transport
have
them.
one for transportation.
If it's an address that is in St. Peters, because we're from Pinellas County. So if it's an address in St. Petersburg, then we have to call the St. Pete Police Department, and they have a team called the call team. They go out and they respond. We set people up with services for counseling, med management, psychiatry, things like that. And then sometimes if they want to Baker act themselves voluntarily, then they still get transported through that. And then we do our follow-ups as well. And then we have care coordinators that do every 2-week follow-ups, and we follow up like almost every other day until they have their first initial intake appointment. And then we
Right, so one traumatic event, or I don't know if it's true, so let me ask, when they're Baker acted, are they Baker acted at that site if they're willing or whatever, even if they have to be committed, are they handcuffed?
Depends.
on the situation
Depends,
with the
okay.
individual, yes.
I've heard that they all get handcuffed because it could be a danger, I'm like, oh my gosh.
Some of our officers have done that. I think
Okay.
it's
It's a safety issue.
It is, yeah.
If I respond to a home where a kid 13 years old is as big as me and he's violent, we're handcuffing
Yeah.
him.
yeah.
But I've
But it's not
transported
everywhere.
adults that have just been, I want to hurt myself, and they just get in the car.
Gotcha.
Great. I like having you guys
Thank
here.
you. Yeah.
We can talk about the specifics. And being from Pinellas, they're our highest volume. So out of all the 10 counties that we answer 988 calls for, Pinellas is our highest volume. So they get more referrals to the MRT service than the other counties do, because just by,
Yeah, and we're also 24/7. So some of us work 4 10-hour shifts, all three, and some of us work 5 days a week. But we all take turns every week. We're on call. So like sometimes we're on call from 10 p.m. to 8 a.m. or sometimes we're on call from 6 p.m. to 8 a.m. It depends. And then at nighttime, like respond. But if it gets real late, then we normally have the cops go out. Unless they truly want to see a therapist at 3 o'clock in the morning. So whoever's on call gets up, get dressed, and we meet with the Leo, but always with the Leo at that time.
Well, what's sad, there's that many people.
Oh, there's,
It's
yeah,
just very
there's a lot, it's a lot.
Yeah.
Yeah.
So what I did in this and the rest of this was really talked about what are some tips and tricks that some people can use. You know, I'm sure a lot of you have this in your toolbox, you've been trained on a lot of this stuff. But if you ever want to talk about, you know, short and sweet tips for maybe people in your personal life that are not part of social services and do not go through all the training that we go through, this may be helpful. So the first thing that we want to talk about is before we start approaching somebody who we think is going through a mental health crisis or who is suicidal, we got to think about our own biases, our own baggage that we're bringing to the game, our own life experiences, and how we feel about suicide, okay? Doesn't matter. We all feel differently on some level about people who take their own lives, but we need to be cognizant of that. And if you have a strong feeling against suicide, you got to put that in check if you're looking to help our clients, because your biases can impact how honest our clients are with us. So all of these bullet points that I listed here are real feelings that people have, even in social services, about people who die by suicide. Some people just think it's flat out wrong. Some people think it's a sin based on their upbringing or their faith. Some people say the cops shouldn't waste their time on people who want to kill themselves. They should go, you know, find people who are really in trouble. Some people say suicide is selfish, and why would somebody do that to their family? Or suicide is just specific to those people who have mental health issues. And the purpose of this is really to, again, put our own ideas and our beliefs in check and make sure that that's not coming through while we're having conversations with our clients, but then also to remind ourselves that all of us are at risk of suicide at some point in our lives. Just because you haven't been suicidal yet doesn't mean that there's not an event that can happen to you that you don't have the ability to cope with, okay? So this is a risk for all of us depending on our ability to cope with certain events. So when we're talking to people who we think may be suicidal, the first thing we do is talk about the warning signs. And there's lots of different ways that warning signs can come across. We've got our direct verbal cues. Those people that are just saying, I just want to die, I don't want to live anymore, I'm going to end it all, or if I don't get that job, I'm just going to go ahead and kill myself. Those are pretty, you know, aggressive and pretty obvious warning signs. But then you have your indirect verbal cues where they're not really giving you the right language. They're saying, you know, everybody would be better off without me, or it'll all be over soon anyway, or who cares if I'm gone, I'm so tired of this, I'm so useless, I'm so worthless. Then you have your situational clues, things that could happen to somebody that could cause them to go into thoughts of suicide. So suddenly losing their job or the loss of a major relationship. Relationship is our #1 reason that people reach out to us as being suicidal. Especially, and Liz is over here, she's one of our chat and text supervisors. Especially on the chat and text side, we get elementary age children as young as 7 chatting and texting us and telling us they want to kill themselves because their friends stopped being friends with them, their girlfriend at school broke up with them. Our kids are having a really hard time coping with relationships ending. So they're reaching out a lot. Liz works on the overnight team. Overnight is busy as all can be. And she gets a lot of chats and texts from kiddos in bed, chatting and texting from their bedroom while mom and dad are sleeping. So when it comes to the loss of a relationship, our kids are having a really hard time processing friendships breaking up and, you know, their version of intimate relationships breaking up. Death of a loved one can definitely cause somebody to turn to suicide. Diagnosis of a serious or terminal illness can obviously turn to suicide. And then loss of financial security. We worked during COVID, we worked through the COVID Cares federal funding, so our organization was awarded the millions of dollars that we had to give out in 9 months. It was $24 million in 9 months that we gave to people to stay in their homes, pay their mortgages, their rents, etc. And during that time, we had so many suicidal people who had never been in the system before, because these were people who were earning 6 figures, running their own business, their mortgages were $7,000 a month and they were fine. Everything was great, they've been paying that forever. And then COVID hit, their business shut down, they didn't get their income anymore, so that loss of that financial security, that loss of that independence, their ability to support their family, had a lot of our upper and middle class people turning to suicide and reaching out to social services, not knowing where to go. So it's a real thing when somebody loses their job and they can't pay their bills. to turn to killing themselves. Then we've got our behavioral clues. There's are things that people can do, maybe not say, that could hint at they might be thinking of suicide. So any previous suicide attempts is going to increase the risk of somebody having an attempt in the future. Acquiring a gun suddenly or stockpiling pills at their house, giving away prized possessions or family heirlooms, or saying, hey, will you adopt my dog? I don't want my dog anymore. Or creating a will to say, if something happens to me, I want you to take my kids over. And it's out of the blue, right? A relapse. If you got somebody in recovery and all of a sudden they relapse, that can cause thoughts of suicide. Isolating themselves from everyone else, not wanting anyone to know what's happening and being ashamed of what's going on in their lives. And then dramatic changes in mood. And I leave this for last because on this section, because it's not just the happy people that become sad. When it comes to dramatic changes in mood, it can also be those people that are normally, they're not really a fan of life every day, and then all of a sudden they show up and they have this euphoric sense about them, and that could mean that they've decided on a day, a time, a way of how they're going to kill themselves, and now they're happy at this decision. Okay? And again, none of this is automatically this person is suicide, but it's a way for you to start to think about, should I start asking this question? And so how do we know if this is a hint that they're suicidal? We've got to ask. And we've got to ask clearly, and we have to be ready to hear an uncomfortable, yes, I am. And we don't want to avoid the question. Especially us in this industry, if somebody comes up to us and wants to start being honest with us about their feelings of suicide, showing an uncomfortable reaction is going to make them feel that I'm bothering them, I'm not going to want to talk about this. And if you are uncomfortable asking this question, is there somebody else that this person can go to? And we'll talk about that a little bit later. So when you ask the question, you want to make sure you're clear, you don't beat around the bush, you don't mince words. You're not going to say, oh, are you doing something that you'll regret later? Are you thinking of doing something bad? We want to make sure we utilize the word suicide. Are you thinking of killing yourself? Are you thinking of dying by suicide? Or if those are too harsh for you and you're not used to it, the last option I gave you, sometimes people who say these kinds of things are thinking about suicide. Is that what you're thinking about? And that's a little softer sometimes, depending on who you're talking to. And if they do say yes, we want to know, have you done anything to start that suicide plan? Because are you safe right now, or do I have to call an ambulance? Okay, so that's our first interaction with somebody who may be suicidal. What we want to avoid is, again, we want to avoid our own judgments, our own biases, our own baggage that we bring into the conversation from our past experiences. So one of the biggest things that everybody tries to do, especially when it's a parent that wants to die by suicide, is to say, no, you don't want to do that because your kids will be so hurt and your family will be devastated if you kill yourself. Trust me, they've thought about that already. And they have come to the determination that those kids are better off without them. I'm bringing down the household, I'm depressing everybody, I'm isolated in my room, my kids miss me, they want to knock on the door and I don't answer them, I'm drinking, I'm using drugs, whatever it is, they think that household will be better without them, right? So trying to guilt somebody into staying alive for their family is not going to work, right? And then telling somebody that, oh, it can't be that bad, it's just a breakup. You know how many breakups I've had? I've had 15 breakups, right? And it's just the straw that broke the camel's back for this person. There's a lot more going on under the surface, and maybe this is that last thing that they just don't have that ability to cope with anymore. So minimizing somebody's reason for dying by suicide is going to break that trust and break that rapport. So when you hear somebody say, yes, I am suicidal, these are some things that you may hear. These are the themes that you're going to hear. You're going to hear about loss and pain, whether it's the loss of a relationship, the loss of a job, the loss of sobriety, it's still loss in some form. Or pain, emotional pain, physical pain, because our chronic illness people, they want to die by suicide too. So it doesn't just have to be a mental health issue, this could also be a physical pain issue as well. When you're talking to somebody who's suicidal and you want to have that conversation with them, you want to make the space safe and open for them. So you don't want to do this in a room full of other people. You want to make sure that you create a private, safe space, whatever your organization allows you to do, as private as it can be. And you want to make sure that their peers are not listening to this so that they feel the freedom to be honest and open with you. And you want to give yourself plenty of time to discuss. If you know you've got 5 minutes and you're worried about this person, you might not be the best person to ask about suicide. Is there somebody else that you can hand this person off to because you got to go to a meeting somewhere down the street? Okay? Don't start the conversation if you know you're going to end it abruptly, because again, it makes that person feel like what they're sharing is not important. So when you're responding to somebody saying yes, that they are suicidal, you want to really focus on feelings. And sometimes it sounds corny and cliche, and all I want to do is solve their problem, get them connected to a mental health professional, and just move on. But without reflecting feelings, doing your active listening, giving them the space to talk, you're going to miss a lot of that story. And yes, they might be suicidal today because they just broke up with somebody, but you're not hearing about the spouse that died 2 years ago, the kids that have gone off to college, the lack of professional or personal supports, and you're missing all of that, okay? So if you're going to interact with somebody who's suicidal, you want to make sure that you're reflecting feelings and giving them that space. If they say they're angry, validate that anger. Of course you're angry. Anyone would be angry if their husband left them or their wife cheated on them or whatever it may be. Of course you're upset. Your dog just died and that's been your partner for the past 15 years. Of course you're frustrated. Social services in our community takes forever and you're scared about being homeless. All of these are real conversations that we all have with our clients. And the most difficult part that people, try to think about is, well, how am I going to find hope with this person? They're telling me how horrible their life is. It sounds like their life is horrible. How am I going to find hope to help this person stay alive for now? So what we talk about is we talk about supports. We talk about who's in your personal life. And if you don't have anybody in your personal life, do you have anybody professionally that we can connect you to? And if you don't, 988 is always there for you 24/7 if you just need somebody to talk to. Then we talk about planning for the future. Are there any plans that you're looking forward to? Are there any goals? Is there anything that you're looking forward to? Whether it's going to the grocery store an hour from now to buy the cat food, or going to a graduation 2 months from now to watch your kid graduate. Any one of those is a plan for the future, no matter how small or minimal that is. Because if they're planning to go to the grocery store in an hour, that means they're not planning to kill themselves in an hour. So how can we get you to an hour and a half? How can we get you to 2 hours? And those are the conversations that we're having while we're safety planning with people. Core values and beliefs. If we get a visitor that hasn't killed themselves because of their faith, man, we hang on to that, because faith is one of those strong belief systems that's very hard to break. So I feel like I win the lotto. Every time I talk to somebody who's suicidal and they say, well, I haven't done it because it's a sin in my faith. Great, let's talk about that and how you can utilize the church, because it's something to hold on to. It's really difficult when you got somebody who says, I don't believe in God, I don't believe in anything, I don't care if I live or die, I've got no family, I don't want a counselor, I don't want this. Those are hard, But when you got somebody who's very strong with their faith, that's a very big piece of hope to hold on to. And then the sense of purpose, oh, I can't kill myself today because I got a report and everybody at work's relying on me. And these are real things that people say. Or no, I can't kill myself because I got to take my kid to school tomorrow, she's got her exams. Or no, I can't kill myself because I'm supposed to be making lunch for my husband's job. I'm an idiot and volunteered for that. Great, because that means that you're planning for something and you're not going to kill yourself until then. So how are we responding? Again, how have you been coping thus far? Was it your dog that kept you alive? You didn't kill yourself because you had to feed your dog every day and you didn't want your dog being alone. Well, now your dog just passed away. So now the dog's not that reason for living anymore, so now we got to find something else, okay? And that's the conversation that we're having. Are there, positive supports in your lives? Are there people that will support you through this conversation? If you're in sobriety and the person that you used to turn to was your dealer, that's probably not a good support system. So let's talk about who else in recovery would be a good support for you. And how can you keep yourself safe for now? When we do our training for our staff, we tell them, and I will tell them in their interviews, your job is not to save somebody's life. That's a huge responsibility that you can't do. Your job is to answer that phone, provide a safe space for somebody to talk about whatever they want to talk about, and then try to help them keep themselves safe. And that could mean for the next hour, that could mean for the next week, that could mean for the next month. Everybody's for now is different. So when we're talking about the safety plans, we talk about if your plan was to use the gun, where's the gun, and that's what I talked about earlier. Can you give it to somebody? Can you lock it up? Yeah.
Is this the same safeplan.org? Because on my work phone, it has an app on there already. It says Safe Plan.
Probably. It's probably the same thing. I had printouts over here.
Right.
Of what you guys, it's a template. So if you guys want to use those printouts and bring them to your office and make copies, go for it. If you want to print them out on your own, the website is there. It's mysafetyplan.org. Vibrant Emotional Health runs the platform. You'll see them branded on those printouts. And really what it does, it goes through those six steps we talked about earlier. What's your warning signs? What's your coping skills? What's your distractions, your buffers, your supports? And how are you going to keep yourself safe? How are you going to detach from your means? How are you going to make your environment safe? If you're going to use a knife, can you put the knife away? Can you give it to somebody else? Same thing with the pills. If your plan is to drive off the side of the road into a tree, can you give the keys to somebody else so that you don't get in the car? Just until until ends.
Yeah, that's one of our actual forms that's in our packet.
Excellent.
That we do when we go out. So we always try to safety plan with everyone. If we cannot safety plan with them, or we can't even safety plan, because I had to go on a call to a group home for a juvenile. We couldn't safety plan with a group home either because she was suicidal, she was cutting, and all that. And then that's when the Baker Act came in.
Right.
But I've told plenty of clients about the Safe Plan app.
Yeah.
And it's just like the paper says.
Yeah.
You can do it also for evacuations, things like that. So
Absolutely, and what we do for us, so on the chat and text side, the staff are chatting and texting saying, hey, I have this tool called safetyplan.org. Do you want to go through it together to come up with a safety plan together? We give the person the option. I can fill it out for you and send it to you because we can text it or email it to our visitors, or we can go through it together. You're on your computer, you're chatting me, or you're on some kind of, online usage. So do you want to fill it out together, and do you want to do it together and send it to yourself? So we give them all these different options, and then sometimes they say, I don't want a safety plan, and we just go through the steps and just word it differently so that we're not safety planning, but we are. So we come up with plans together just based on how cooperative the client is. But you're right, if they're not willing to safety plan, if they're not willing to collaborate, if they're not willing to confirm that they're going to keep themselves safe for now, then we normally would have to default to an active rescue. But that's not common for us. Most of our people want to talk. Encouragement is huge when it comes to talking to our visitors. And when we talk about encouragement, we're talking about, I'm so glad you reached out today. I'm so glad I'm getting a chance to talk to you about what you're feeling today, because that means that you're not going through with your suicide plan right now. So let's talk about what you're feeling. And then also we want to encourage them when we get to the end of the conversation. It sounds like we came up with a great plan today. Are you still confident that once we hang up, you're going to go do this? And plans can be as prolific as I'm going to go to my appointment tomorrow, and I'm going to go call my sister, and my brother-in-law is going to come stay with me for the next week. That's a big safety plan to keep somebody safe. Or it could just be, as soon as we hang up, I'm going to go watch the Kardashians for an hour, or I'm going to go to sleep, or I'm going to go cook my family dinner, or I'm going to go walk the dog, or I'm just going to sit here in silence. Great, because all of those are a thing that you've confirmed is going to keep you from going through with your suicide plan. And when we end a conversation, we always remind them, if when we hang up, you can't do that first step, it's too hard, call us right back. We're here 24/7. We can talk about this again and come up with a different plan for you if this doesn't work as soon as we hang up.
So if they call back, do they get the same person?
No. And well, depends, how many people are working that day. But typically you would not get the same counselor. There's so many counselors across the country that are backups, primaries, national backups. And we have several counselors each shift working as well. And it's kind of on purpose. We'll have some callers that say, I want to talk to Betty. She was great. I only want to deal with her. That's a codependent relationship, and we're not going to go there. I'm the boundary queen at my job, so I'm pretty strict about boundaries. And so we have language that we tell people. We have active callers and frequent visitors that come through every day, multiple times a day, that just want to talk to one person. They all get the same message. We've all been trained the same. I can't transfer you to somebody else, but I'll be happy to talk to you. And sometimes they say, nope, I'll try again, click, and they'll call back and just try to get that same person on the phone, and it never works. But letting them know that, hey, you've done a great job, we've come up with a great safety plan together, I think you have the tools you need to get yourself through the rest of the night, or the rest of the day, or the rest of the morning, or the next hour, whatever that may be. And again, if it's too hard for you when we hang up, call us back, we're here 24/7. And then we always remind them, 988 or the crisis line is available as well if they don't want to call you or somebody else. So then who can help? So 911, again, we follow least invasive, so they are going to be only called in cases of someone that won't collaborate, someone that's way too intoxicated, high, hallucinating. We have a hallucinating person that reaches out to us when the trees are walking across the front yard. And if they can't collaborate with us because they're too intoxicated or too out of touch with reality at the moment, sometimes we gotta get 911 involved for safety reasons. The 988 Suicide and Crisis Lifeline, we're here 24/7. Please push this number as much as you can to any and all of your clients. 211. 211 is a national initiative all across the country. Doesn't matter where you live, 99% of the country is covered by a 211. So anywhere you go, there is a 211 that covers that location. So 211 is pushed a lot for local resources and other programs in the community. They're our health insurance provider. If you're working with somebody who has health insurance, probably, especially nowadays, there probably is some kind of coverage for mental health services. And if there's not, 211's got free and low cost services for people who don't have coverage. And then securing a plan to remain safe until help is found. So again, that's just confirming those last steps of safety before you end the conversation or before you hand them off to the next entity. Once you are done having this interaction and this intervention with someone who may be suicidal, you want to make sure you take care of yourself. So that training I talked about in the beginning, that assist training that I do for Living Works, I will only schedule that training on Thursdays and Fridays. Why do you think I will only train that course, a deep end, intensive suicide intervention skills class, on a Thursday and a Friday?
Enjoy the weekend.
So I don't have to think about suicide for the next 2 days after that class is over, okay? Self-care is very important, and it's not just about your breathing techniques, okay? If I get told one more time, breathe deeply, and hold it for 5 seconds, and release it for 10 seconds, I swear to God. So no, we're not gonna talk about deep breathing exercises, or going for a walk, or journaling. No, we're not gonna do that, okay? What we're gonna talk about is know when you are not the one, okay? I know I am not the one after I teach an assist class. Okay, if any of my personal loved ones comes to me on the Saturday and Sunday after an assist class and says, Kim, I gotta talk. Okay, are you okay right now? Are you safe? Yes? Let me connect you to 988 and let me pass this off, because I'm not the one. I am in a place where I am so overwhelmed and overstimulated. Liz knows, she's been to that course. There's crying in that class, and at least half the class cries at some point, and it's very emotionally draining. So if somebody comes to me and they need some kind of de-escalation, they already know. I've already set those boundaries with my loved ones. I'm going to give you to somebody else. And so you guys have to do the same thing, all right? You can't always be that go-to person. All of our loved ones know where we work, wherever you work, and they always come to you with their problems, and sometimes you just can't be the one, okay? And if you feel that you're being burnt out by the cases that you're taking on, do you have an EAP program at your agency? Do you have your own health insurance coverage? And does your health insurance cover mental health services? Find out now before you get burnt out. Because by the time you hit that point, you're going to be so exhausted, you're not even going to want to research it. So if you find out now what your options are while you're okay, assuming everybody in here is okay, then by the time the burnout comes, because it's going to come, none of us are, immune to it. By the time that burnout comes, you already have 2 or 3 options of what you can do to help yourself, okay? Make sure you use your PTO time. I know we are all an industry that hates to take vacations because people need us. No, we need us, okay? We need each other. We need ourselves. We need to make sure we use our PTO time. And make sure you have a list of things that you enjoy doing so you don't have to think about it when that time comes as well. If you know you go for a walk every day at 6 o'clock and you have a really bad day, should you skip that walk, or should you make yourself go for that walk, because that might be something that you have to have for self-care. Just depends on you and what your preferences are. Okay, did I make it? 7 minutes to spare. I did.